thank you for joining me again as part of my pandemic diary. As I've mentioned previously, this is our chronological recounting of what was happening as part of this pandemic. And we started before the pandemic. We started in November of 2019, and now we're up to June of 2020. So it's about 3 to 4 months into the pandemic as we knew it in Kentucky. And we have dealt with issues such as testing and what was happening in hospitals and with healthcare workers. Now I want us to look at what was happening at this time in our aging population. And so with me today, I have Amber Gensheimer, who will talk with us from her perspective. Amber is in a leadership position in infection prevention and control with Signature Healthcare, and has been someone who has seen what is happening, looking at the experiences, and was here at the very beginning as we begin to recognize this in our aging population. So Amber, thank you so much for being part of my pandemic diary. And I'd love to hear from your perspective, if you can describe what was happening in long-term care facilities about this time in June of 2020.
Okay, well, thank you for having me. And yes, as the pandemic is gearing or, getting to grow and we're seeing its expanse across all, healthcare settings. One of the things, that we are experiencing in long-term care as an industry is, kind of some of the things that you touched on. We're still experiencing, a lack of the ability to have tests for the, all the needs that we have, to meet the needs of testing for our residents and healthcare providers and things like that. We're experiencing, lack of or the constant need to try to source PPE or personal protective equipment and things like that. But more importantly, we're starting to learn that this pandemic truly, impacts the patient population that we serve every day. The elderly, the population has a lot of comorbidities. They are frail, they are immunocompromised, which really fits the description of the people who this virus is impacting most. And so, to do, care for these patients, we have had to implement across our industry a lot of, precautions to, try to keep them safe, like keeping our, limiting visitations and restricting actually visitations so that we do not allow, visitors to come into the facilities. And so just that aspect alone has played a huge role on the, psychosocial needs of our residents and, of course, family members who are used to being able to come in and visit their loved ones are no longer able to do that. So we've had that issue to deal with, add into that the other aspect of, the knowledge that we are starting to gain that this virus is, more of an airborne type illness, or there's still a lot of controversy as to whether it is truly an airborne illness or a respiratory illness caused by droplets. And so, having to try to, implement programs and policies and procedures and things like that for PPE that we're not used to using, such as respirators. We've just never usually cared for that type of population in the, long-term care industry. So that's something new for us as well.
So yeah, many of the changes that have occurred where we're now testing and checking temperatures before people come in. And we are thinking that that's going to be our primary way of identifying people who are ill. That although we know that there is asymptomatic transmission, we are seeing that people that have no symptom that are able to be infectious, we're still primarily focusing on fever as our first a recognizable event. And that may work for healthcare workers, but we know in the aging population, fever may not be, be able to be determined in individuals, that an elevated temperature may not be a sign of infection. So we're somewhat hobbled with identifying early identification, and we still don't have enough tests. Our healthcare workers now, with the restrictions of visitors, are taking on multiple roles. That they are now the recognizable face for many of the residents, the only recognizable face in many instances. And now we're also having people wear masks, and so or N95 respirators. So now the recognizable part of the person is hidden behind respiratory protection, which may be concerning for a number of the residents, causing fear that everything is changing, where their family members, and that the healthcare workers now are providing not only the care, but also the psychological care that oftentimes was provided by family members who are able to come in. We now have healthcare workers that are wearing personal protective equipment for which they have very little familiarity. As you mentioned, long-term care, we've not had N95 respirators because that has almost been used exclusively for diseases that are very rare in long-term care, tuberculosis or chickenpox or disseminated shingles, which doesn't happen very often in long-term care. So we're having then to develop fit testing programs, or at least fit checking processes. So a lot of training is going on, and as you mentioned, trying to source personal protective equipment. So maybe one type of mask today, and next week it's something different. So a lot of change is happening. At the same time, we are learning about this virus. Every day it seems like our guidance was different. And then today it was like, handle it this way. And then as we learn a little more, then we'd have updated guidance from CDC. So in long-term care, then how were we managing if we have two residents in long-term care that developed illness? How were you managing that in trying to either cohort or protect other residents from transmission? How was that being approached this early on into the pandemic?
So that's a great question. And one of the things that I think is, for those of us in healthcare, if you've never worked in the long-term care industry, we have to quickly remember that this is the residents' homes. And so unlike in a acute care setting where you have, private rooms, and a lot of them have the ventilation appropriate to care for types of patients like we just discussed, with tuberculosis and this new virus that's coming out that we still don't know a lot about. And so, when we in the long-term care industry have to care for a population of, individuals with this illness that we still don't know a lot about, where they have roommates or, residents go out and about and they go to different activities and things like that. So it's really trying to get a handle on, we've really been working on, of course, we've had, regulatory input, and we have regulations that we have to follow, which, has, again, like I mentioned, we've had to, stop visitation and things like that. But, we've, as you said, the guidance changes almost daily these days. And so, really making sure that, one of my major responsibilities or roles is to, keep up with those regulations and the changes so that we can, pivot as needed. But, trying to keep this population safe when you have positives occur, it's just, you have to err on the side of caution. So we are, doing that. And, if we have a positive occur, or a resident that's symptomatic, we go ahead and isolate them. We really, in this industry have been trying to create areas, where we can house positives or residents who are who may have been exposed but aren't symptomatic yet, to try to decrease the risk to all the rest of the residents, and hopefully mitigate the risk of outbreaks and things like that. So that's one of the big things that we've been trying to do in long-term care as a whole.
And so I'm trying to do all of this while still not having enough tests to actually be able to go and test everyone.
Correct.
at this time, then we would almost need a crystal ball to try to figure out who needs to be tested if we have limited numbers of tests. And in June of 2020, we would not have had enough, we didn't have enough tests to be able to say, we've had a number of cases we've recognized or we thought were positives. We did go ahead and get a test done. It may have taken us several days to get results back. And so now we have then potentially healthcare workers and other residents who are exposed. So we're chasing behind this very clever virus and then trying to test people that we think may have been in a situation and move or cohort people at that time, closing off then, changing the way that people were able to dine, that no longer can the residents come out of their rooms. So we're bringing meals to them. So we have residents who are isolated because of the disease and those that were isolated socially. So we're dealing with, with all of those situations, and still we're in the dark with trying to figure out who is infected and who isn't.
Well, and that's a good point you brought up, is that, even the few tests that, are available that we can use, and we have to identify, who we need to test, but the tests are still taking a long time to return. So, by the time you've tested someone, if you're not taking precautions, to keep them separated from other residents, if a test results in 5 days from now, it's way too late to be trying to make those moves now. So really trying to differentiate, as you said, identifying the staff and the residents who, need to be tested, and then anybody who potentially has been exposed to those, and kind of keeping them separate as well. And, all the movement throughout the facility, and, just makes it a little bit difficult to manage. So.
Yeah, now, in the acute care setting, we, about this time, and interestingly, the use of masks by everyone has not been part of our care up until this point. So we're just beginning to say universal masking for everybody, but we will still have people that, and especially the healthcare workers, that as they try to get a few minutes to go, get a drink and get something to eat, may have several that will gather together in a break area, because now we're also using spaces to enable us to separate our residents. So the ability to have a break room, it may be a luxury in some long-term care facilities. So we may have several healthcare workers that will gather together in a room just to be able to eat quickly. And that means everybody's mask is off. So we go back to chasing the individual opportunities that are there for transmission. Because in this early part of the pandemic, we're looking at how long do we think it takes between exposure and when symptoms will develop. And this is, several days, maybe up to a week at this point. And we still don't have enough tests to actually know if that's true. But we have healthcare workers that still, despite implementation of these types of infection prevention and control activities, the need for people to get a drink and the need for people to get something to eat and the limited space still represented transmission opportunities that we still don't fully understand. And many of us are thinking, if we can just make it through this wave, we talked a lot about, that thinking in our minds that just like the ocean, this wave will pass and we'll be able to be back to normal. So many of us are thinking, can we just get our healthcare workers to hang on and stick with us through this wave and help people, kind of get through what we think is going to be the only problem. And so were there some things that you were thinking about, with your with your healthcare workers in how do we communicate with them? And what were some strategies that you use to try to keep your healthcare workers and the resident, their families, up to date on what was going on? Because everybody's wanting information. And as we talk, the information changes every day. So now we're trying to help people understand that if I tell you something today that is different from yesterday, it doesn't mean that I was wrong yesterday. It meant that was what we knew yesterday. So what type of strategies were you using then to communicate?
Well, one of the things that we got very used to doing is, we would, as the changes came through, whether it be CDC changes or regulatory changes that we needed to implement, of course, we had, we developed an infection control committee, an internal infection control committee that was holistic, had representation from, pretty much all of the big departments within our organization. And, just that communication and updating the policies and procedures. And, a lot of times we would host virtual webinar sessions, where the facilities would attend and disseminate the information that way. We used emails, and we created a catchy, like a COVID update. We even had a label or a thing that we've used throughout the whole pandemic so that it's easy to identify when there's a change coming out that the facilities know, because it's always going to be on that with that header. But, we utilized websites for family members. We posted signs on the doors. There's just a ton of ways that we have recently, began communicating.
So just the whole art of communication.
Yes.
Whether it was, none of us were used to, it was interesting, connecting via Zoom is not our main way of communicating in June. We're still face to face, and we're not thinking about healthcare as being a remote, having an element of remote. So we're trying to come up with ways of sharing information that does not require face-to-face communication.
Correct.
So developing these approaches, having people be willing to accept communication in new ways, and being willing to accept the fact that the message I'm giving you today may be different from the message I gave you yesterday. And doesn't, it's just that evolution of developing trusted communication in the middle of a pandemic where we're still in the dark and feeling our way.
Well, and you brought up a good point. Keeping our family members up to date and informed, especially since they're now not able to come in and visit their loved ones, we just recently started sending out, letters to the family members. Anytime there's a big change, that's going to be our process moving forward, is, to keep that open communication and just let them know, okay, here's the latest changes. And, we know that this is a very fluid pandemic that we're in right now, and we're still getting lots of new information daily. So just so that they know that, the communication will be there, and we're working to develop a call center so that families can call at any time, day or night, to get information about their specific, residents. And I think that's something that in the long-term care industry as a whole, we had never really had that capability before.
I think, earlier as we've gone through my pandemic diary, we've talked about, how we were calling healthcare workers heroes, that they would come to work and under, conditions every day where they didn't realize, what was going to happen to them. Is today the day that they are going to be infected? Is today the day that they may inadvertently bring the virus into their work setting? And, we know from healthcare workers that are in long-term care facilities that there is a genuine love for the aging population, that, that seeing illness among an older individual, we know that death is part of life. And it's the worst part of life in many respects. But when we're dealing with the older adult, we are accepting that that the older adult is getting closer to the end of their life, but we don't anticipate being an active participant in that process. And so throughout this period of time, I've been so struck by healthcare workers that their anguish, their emotion at what they are seeing has been just so open. And the concern for the residents among the healthcare workers in long-term care has been just, I've seen it, just the anguish on the face of the healthcare workers as we have spoken with them. So I know trying to help people deal with that has started very early in the pandemic, and there may be some things that you have thought about in a leadership position. What is it that we can do to help our healthcare workers deal with what they're experiencing? Because we need them to come back to work. We need them to willingly come back in and face this every day. So, are there some things that you are learning during this early part of the pandemic to help with this?
I think that one of the things that you brought up that is important to note is that, the fear, there is fear, and it's real, because there's still so much uncertainty. And then, you come into work every day and you don't know if who's gonna, if the virus is going to get into the facility today, or into a building, or into, new long-term care facility, not just, this is just across the whole continuum. And, I think one of the things that has really helped, or that we are seeing, is that communication, just, as a leader, and as, leadership, those people who are in those leadership roles, just, us getting out there and helping, and, delivering supplies, and, offering that comfort. And, that has gone a long way, as well as, I think the relationships that healthcare providers build and have within, among the residents and family members, and the other healthcare providers in the facility really has helped give them a why, as to what they're doing. And, you mentioned the difficulty, and the fear, people have families, and, I'm sure they're concerned about bringing the virus home to them as well. And, not knowing, knowing that there's no treatment or anything right now has been difficult, but yet we still see them coming in day after day, and that's been one of the greatest things to watch as a healthcare professional, seeing the support that we offer each other, and the support the community offers. And, one of the things you mentioned, this just is a perfect example of that, is, in the healthcare, in the long-term care world, we hadn't had, to wear respirators before. And so, with that, you're required to, as you mentioned, fit test or check the fit and things like that. And we've had people come in and help, do those types of things from the community. So whether it's somebody from the health department, or, fire department and things like that, so it's really neat to see those people come in and lend a hand. And I think it's those things, all those little small things combined, that really give us our why to keep coming in every day.
I think I liked, something that you said that just came out so naturally, and that was that you were there with your team, and that this really is something that we are all experiencing, that in order for us to make it to the next month through this pandemic, that we have to be here together. And that this is not the time for people to be, at home in the basement, hiding in the closet. That maybe that's the safest place. We don't know. But if we're going to be able to be successful, we're successful together. And that, being part of the healthcare worker community, and being willing to enter these environments, knowing full well that we're at risk, but this is how a community works together, and that how a community survives together. It's by people being willing to bring their skills and looking around the communities, you mentioned having our first responders helping us, helping us get through certain needs or supporting us, and the health department, although there are not a lot of personnel in our local health departments, but they're there with us, they're beside us as we care for our community. And this is why we have focused so much on protecting the critical infrastructure of healthcare from start to finish across all settings, that if we don't have a strong healthcare infrastructure, we can't address what is happening in the community. So your description today, Amber, of what was happening in long-term care during one of the earliest months of this pandemic in June of 2020 has helped us understand how this was unfolding, what we knew at that point, how we were operating at that point, and helping us try to prepare for what was to come, has demonstrated the need to communicate, to be beside each other, work together, engage families as we are here together to take care of these vulnerable aspects of our population, specifically our older adults, where so much is happening, so much that we don't know. But at the end of the day, what we realize is that they need us. The population needs us. And as healthcare workers, our responsibility is to be there. So thank you so much for being with me today. I welcome you to stay with us. And as we look forward to what happens and what is happening in July, we will provide that information as a next segment of My Pandemic Diaries. Thank you so much for being part of this.
Thank you. It's my pleasure.